Greetings, this is Dr. John Bennett, televising from Miami Beach in the background. We have the second in the series of Daily Dose of Neurosurgery Education with Abe Sherian. This is number 2. Let's meet a couple of the panelists before we turn it over to Abe. Hello, Manuel. Go ahead, Manuel.
Hello, John. How are you? How are you, Professor Sherian?
Absolutely fine, Manuel. Good to see you.
Good to see you too, Professor.
Manuel's strolling around the streets of Moscow, right?
I am in my way to hospital, but I stop because otherwise I don't gonna have time because I'm gonna take the metro to the hospital, and in the metro I don't have good. I don't have internet. I don't have connection. So
okay.
I stop in the magazine. I sit, I take the class, and then go to the hospital.
Okay, very good. Okay, welcome, Khalif. You're just arriving here. Can you hear me? Go ahead, Khalif.
Yeah, thank you so much, John. Thank you. I'm joining you with my phone today, so I'm in a hospital. So
how are you, my friend?
You can do that. You can do that. Hi,
yeah,
Fez. Are you there? Are you there? Hi, Fez. You want to introduce yourself? Possibly not. Okay, welcome, and it's all yours.
Right. So this class, we're going to talk about anterolateral skull-base surgery. Now, here's the skull. Okay. If you're going to look at it, you're going to find a few peculiar features of the human brain and the skull. The first peculiar feature is that the skull, a lot of bones in the skull, forms the base of the brain and insinuates into the brain. It gets into the brain. So much so that at some point, if you don't know your anatomy, you don't know at what point is the brain and what point is the skull. So this is very important. So for example, you see the tuberculum there. You see the anterior clinoid there. You see the petrous apex there. These are all in very intricate relationships with the skull base and the cranial nerves and the vessels. And if we get millimeters out of drilling these structures, you're going to have operative space to take out tumors, to drill, to clip aneurysms and so on. Now, what is the principle of anterolateral skull base, which is the most common approach done anywhere else? I mean, this is done for cystinostomy also. That means for trauma. And trauma is one of the most common approaches. So we're going to talk about that first. Number one, I'm not going to show you many drawings or anything. I'm going to show you how the brain is. So do you understand when I say this is the frontal lobe and this is the temporal lobe? Everybody understands? There is a folding like that. Do you understand that? The frontal, when you draw the brain in 2 dimensions, you're going to draw this. For example, anybody who can draw me the picture of a brain, anybody? Like yesterday, can somebody draw me the picture of a brain? Khalif or Hafiz or, okay, if you don't have the paper, I'm going to draw it for you. You see that? I got a problem with I can't see that, so I know. Okay, I think I cannot. Okay, can anybody, because of this background, I think it's because I cannot show. Okay, I'm going to show it with my fingers again. All right. So this fold, are you able to see me? Everybody looks frozen. So are you able to follow what I'm saying? Everybody? Manuel's screen looks frozen.
You hear me? Okay.
Yeah, Manuel, can you hear me? Everybody, can you hear me? So this is the first fold.
Yes.
Yes, we can hear you, Prof.
Frontal lobe, temporal lobe. This fold is in what plane? It's in the sagittal plane. Do you agree with me? Do you agree with me? This is the sagittal plane. So if I make a cut like that, you will find this fold. That is called the sagittal plane. So this lock, this folding is called the sagittal folding of the brain, frontal lobe and temporal lobe. Do you agree with me? Yes? I think the internet for people, yeah. Are you hearing me?
Yes, we are hearing you.
Yes.
Yes.
I made the drum, Professor. I sent to you of the brain. You asked us.
Okay, right. The second folding, the frontal lobe here, the temporal lobe here on the side. So the first one was like that. The second folding is like this. So the frontal lobe, basifrontal region is here. The temporal lobe is here. So when you have the temporal lobe, this is the axial fold. The first one we talked about was the sagittal fold. This one is the axial fold. What is the axial fold? Axial fold is the temporal lobe is like this. Okay? This is the second folding. And the last fold is the Sylvian. Sylvian fissure is intradural. So you have an oblique fold. So you have, it is not axial or sagittal, but it's an oblique fold where you have the frontal lobe like that and the temporal lobe. So you open the Sylvian and then you will reach the base of the brain. You know, before extensive extradural skull base work was practiced, Yasagila and his school primarily used Sylvian dissection to get into the skull base. If you look at all these masters, Yuha, Yasagil, many of those masters from this region, they used the Sylvian fissure primarily to get into skull base. I mean, everybody knows that if you want to do a craniopharyngioma, you want to do a basilar tip aneurysm. By the way, aneurysms are skull base pathology. Yeah? If you want to do a ACOM aneurysm, if you want to do a planum meningioma, you need different degrees of Sylvian dissection. So Sylvian dissection is intradural unlocking. So what is it? It is a oblique fold of the brain which you are unlocking it. Atraumatically, you are unlocking it. Atraumatic unlocking is a trick. I mean, it's an expertise. Some people do a very traumatic unlocking of the Sylvian dissection. I mean, they do a very traumatic Sylvian dissection. That's not correct, okay? But beautiful Sylvian dissection is a way of unlocking the oblique lock of the brain. But what about the first two locks? The first two locks, sagittal unlocking, how do you unlock in a sagittal direction? You take off all the bone between. You take off this bone, that is the orbital roof. You take off the lesser sphenoid wing. You take off the clinoid. You take off the greater sphenoid, little bit of greater sphenoid wing laterally. And this is unlocking the brain in a sagittal fashion. This is extra. This is bone drilling, where you unlock in the sagittal fashion. And how is axial unlocking done? Axial locking is like that. Axial folding is like that. So to get into the interpedunclar fissure, which is my this thing, let's say the basilar is here. So, you know, how do you unlock? You take the temporal lobe off the cavernous sinus. You take the temporal lobe off the cavernous sinus. This is the secret and the genius behind Dolling's approach. Transcavernous dissection is a genius technique to take off the temporal lobe away extradurally. You know, the Japanese modified it into the intradural temporal mobilization for basilar tip, but Dolling did it extradurally. So what he did was he took off the temporal lobe, lateralized the temporal lobe away from the cavernous sinus, so that getting into the interpeduncular system, that is the posterior most part of the skull base, the brain base, was easier. So these are the three unlockings. Sagittal unlocking. How do you do sagittal unlocking? You drill off all the bone and then up to the clinoid, and then you create space in the sagittal plane. Axial unlocking, how do you do it? You manipulate the temporal lobe. I mean, you don't manipulate actually, you just pull back the temporal lobe. This can be done bloodless. So if you know your orbitomeningeal band anatomy and you follow a few papers and see how we do this, you can see it on YouTube so many times. You can see that you can cut this orbitomeningeal band and you can go take it back, and then you could go ahead and mobilize the entire temporal lobe back, so that you can get into for basilar tip aneurysms and things like that. And the third unfolding is the Sylvian dissection, where you go ahead and do a Sylvian fissure dissection, get into the base of the brain. So today's class is the basic principles of anterolateral skull base. And after that, we will be showing you examples of this in the coming days, like a basilar bifurcation aneurysm, like many cases where we have to do a axial unlocking or a sagittal unlocking or a Sylvian dissection. So we're going to show these examples later on. So as long as you understand the three principles behind getting into the anterolateral, not skull base, to the brain base, you kind of understanding as to what a skull base surgeon is doing. Thank you very much.
Thanks, Ike. Do you want to, any comments or questions from the panelists, please? Oh, let's meet a few new arrivals. Dr. Boniface and Joanna, do you want to say hello? Introduce yourself to Ike. I don't know if anybody's hearing me today.
Okay, I can hear you. Thank you for
yeah.
the good lecture. I'm Dr. Boniface from Tanzania.
Oh, welcome.
I can hear.
Welcome.
Yes, yes. Thank you very much.
Hi, Boniface. Did you understand what I was trying to say, Boniface? Did you understand what I was trying to share?
Yes, because I started a bit late, so I've gained a little bit. So maybe if you continue, then I can get more and more and more.
Yeah, I'll send you the recording, Dr. Boniface.
All right, thank you.
Don't worry about it, John. I will tell him once more.
Okay.
So there is no problem. So this is the thing, you know, class, we are not worried about the time or anything, repeating it. So Boniface, so listen.
Yes.
You imagine this is the frontal lobe and this is the temporal lobe. So the brain is folded like that. You know that, right?
Yes.
So that is the sagittal plane.
Yes.
And the brain is also folded like that. This is the frontal lobe, this is the temporal lobe. So the brain is also folded like this. So Can you see that in the axial plane also the brain is folded? Do you understand me?
Yes, I understand.
So you have an sagittal folding and axial folding. And then in the very end, you have an oblique folding. That is, the frontal lobe is like that and the temporal lobe is like that. So you have a oblique folding intradurally. That is a Sylvian fissure. So if you dissect the Sylvian fissure, you can get into the base of. So this is what, these are the 3 foldings of anterolateral skull base surgery. So how do you address each of these foldings? So for the sagittal folding, you drill off your orbital roof, your lesser sphenoid wing, your anterior clinoid, your little bit of your greater sphenoid wing, all that you drill off, you will be able to do a sagittal unlocking. If you are able to take off the temporal lobe extradurally from the cavernous sinus, this is Dolen's approach, okay? We will show you Dolen's approach. If you are able to take off the temporal lobe laterally, we will be able to do a temporal, extradural temporal mobilization, and this is called axial unlocking. And if you are able to dissect the Sylvian intradurally, this will be the 3rd unlocking. It is called the oblique intradural unlocking. So by these 3 maneuvers, you can get the entire skull base beautifully laid out before you. So this is the principle of the principles of the 3 principles of anterolateral skull base approaches. This is what we were discussing. And from tomorrow on, Boniface, we will be showing, tomorrow we will show you a cadaver dissection where I show all 3 unlockings. All 3 unlockings very clearly, okay? Tomorrow we will show you a cadaver dissection. And from then on, we will show you aneurysms, skull-base tumors, where we are using these principles, and then you will understand what I am doing, okay?
Thank you very much.
You're welcome. Very well.
Okay.
Okay, any other comments or questions for Ike? Okay, Ike, well, does anyone else have something to say? Perhaps not. Okay, Ike, I guess we'll see you tomorrow. And the topic tomorrow is
Cadaveric. So tomorrow will be cadaveric dissection depicting all 3 unlockings.
very good. Okay, great. Thanks, Ike. Thanks everyone for coming.